Welcome to the NLA session on the use of coronary artery calcium scoring to reduce atherosclerotic cardiovascular disease risk. I'm Dr. Carl Oringer. I'm an associate professor of medicine at the University of Miami Miller School of Medicine in Miami, Florida, and director of the Preventive Cardiovascular Medicine program at the University of Miami Health System. And I'll serve as the moderator for this session. Before we start our session, speaker presentations can be found under the File tab on the right-hand side of the page. Under the chat tab, you will be able to ask your questions to the speakers. I had the privilege of working with Drs. Matthew Budoff and Michael Blaha and 6 other co-authors who collaborated to create a manuscript related to this presentation. This manuscript is available on the NLA website, www.lipid.org, and will shortly be available at the Journal of Clinical Lipidology website as well. It addresses a series of clinically relevant and practical issues regarding the use of coronary artery calcium scoring in clinical practice. Our first speaker will be Dr. Matthew Budoff, and he will be speaking on coronary artery calcium testing and interpretation. Dr. Budoff is a professor of medicine at the David Geffen School of Medicine at UCLA and the endowed chair of preventive cardiology at Harbor UCLA Medical Center. Dr. Budoff.
Hello, I'm Matthew Budoff. I'm a professor of medicine at the UCLA School of Medicine and the program director at the Lundquist Institute in Torrance, California. And I was asked to give the first half of the National Lipid Association update on coronary calcium scoring. And the second half will be given by Michael Blaha from Johns Hopkins immediately following this talk. So as far as what I will be covering today, I'll be covering the performance and reporting standards of doing coronary calcium, the guideline recommendations, a little bit of discussion on race and ethnicity, and then how we manage incidentally found pulmonary nodules and incidental coronary calcium found on chest CT. So part 1 of the statement discusses performance and reporting standards, reproducibility, and significance of absolute scores versus percentiles. So if we think about what is a normal coronary calcium score, just as a quick review, there's no atherosclerosis, or at least no calcified atherosclerosis present on the scan. This is a sample image. Obviously, we take a series of images from top to bottom. Usually a calcium score is about 30 to 35 slices of data, axial data on a CT scan. That gives us a total view of the coronary artery anatomy. So we can then sum all of the calcified plaque in the coronary tree and get a number. The computer does the scoring, so it's very reproducible, but as far as the actual scoring goes, and we'll talk a little more about reproducibility between scans in just a moment. This is an example of somebody with severe coronary calcification. You can see within the yellow circle, the severe calcified plaque. That's obviously just one slice, but when you add up all of these calcified plaques and the computer sums the total calcific plaque volume, you end up getting a score that can be used to either track atherosclerosis or more commonly to assign risk for that individual patient. So these are the calcium score scores and cardiovascular risk assessment. These are the typical scores that we use. So a score of 0, plaque burden is none or minimal. Implications for cardiovascular risk is very low, what we call the power of 0. And I know Dr. Blaha will talk more about this. Calcium score of 1 to 100 is mild atherosclerosis. 100 to 400 is moderate plaque burden, and risk is considered high. And these are usually where the guidelines say that the risk is higher. And then greater than 300 is severe plaque burden and a very high cardiovascular risk. Some people even have scores greater than 1,000 as a category, and that would be considered extensive plaque burden. So this is just showing us how we do the calcium scores. These are the parameters that we use. So always done with a tube voltage of 120 kilovolts, very important. If you decrease the kilovolts, you would decrease the radiation exposure, but you would make the calcium brighter, and you would increase the score compared to how we've typically measured it. Another way that we can control radiation, though, if we can't change the voltage, is to change the power or the milliamps. So we can use a variable tube current, and this is based on the patient size. So big people get higher currents, more power, and smaller people, thinner people get less, and that's a way of controlling the radiation and maintaining image quality. All of these images should be obtained in an axial mode, in other words, prospective gating, axial slices, very low radiation exposure. Typical radiation is about 0.7 millisieverts for these studies. We obtain images in 2.5 to 3 millimeter slices to calculate the Agatston score. Some people believe that it's helpful to use thinner cuts, like 1 millimeter slices, to find smaller calcific plaques, but typically we just use the 2.5 to 3 millimeter slice reconstructions for a standard Agatston score. This is the how we calculate the Agatston score. We use a density, peak density or maximum density of the individual calcific plaque. And then we use that as a coefficient and multiply that times the area of calcium. So the computer measures the area of the lesion, and then it multiplies it by 1, 2, 3, or 4, depending on the density. Densities of 130 to 200 would be a multiplication of times 1. 201 to 300 would be a coefficient multiplication of 2, and so on. And that would give you an individual plaque's calcium score, and then you would sum all the plaques in that both distribution of the vessel as well as in the total heart to get a total calcium score for the patient. We typically focus more on the total score than on the per lesion score or on the vessel score, because that's where most of the prognostic value has been derived. So a total Agatston score is how we derive the data. So the next question is, how reproducible are calcium scores? And what you can see here is a comparison between a multi-detector CT, a 64-slice CT, and an electron beam CT. This is data from my lab that we published now more than a decade ago, but just showing you that when you get a score on one study and you transfer the patient to another location, you get a very, very high correlation. Here the R-squared was 0.97. So a very high correlation between the calcium scores between the original way we did these scans with electron beam tomography and now how we currently do them with multi-detector CT. This shows us the inter-scan reproducibility. So these are different scanners. These are mostly 16 and 64 slice scanners. You can see reproducibility varies between about 12% and 17% between two scans on the same day. So there is some reproducibility issues with coronary calcium, and that's probably based on differences in how the patient is positioned, how we catch the calcific plaque as we scroll through the images, and how the reconstructions are done. Newer machines, like 256 detectors or 320 detector machines, have shown lower reproducibility, better reproducibility, and lower percent variability between patients. So the next part of the statement talks about how useful are calcium scores in age, gender, and ethnicity percentiles. And basically what's advocated for is to use this MESA risk calculator. So the website is on the top there, mesa-nhlbi.org, CAC reference. But you can see that it's a risk calculator that was created based on the multi-ethnic study of atherosclerosis patients. It incorporates age, gender, race, and ethnicity, asks questions such as diabetes, smoking, and then puts all of that into perspective for the patient, and then calculates a risk score based on their calcium score, or shows you what their estimated calcium score would be based on their age, gender, and race. Now, This is just a table from the paper. You can see the absolute coronary calcium score is the best predictor of the absolute cardiovascular risk, and that's used in all patients. So we report the absolute number, again, 0 being the best, no calcific plaque, lowest risk, greater than 300 being the worst, high risk. We also have a calcium score percentiles. So you can say, okay, based on the average gender, women or men, race and ethnicity, that score is low or high for that person. So for example, a 50-year-old female may have a score of 5. That might be considered on the high side for her. That's a low absolute score, but a high percentile risk because a 50-year-old female should have very little plaque. So this is most useful in younger patients where they don't tend to get huge absolute scores. Most younger patients don't have scores above 100 or 300, but they might have more calcific plaque than they should based on their age, gender, and race ethnicity. It also may be helpful in older patients over age 70, where most people will have a score above 100, but now you can say based on other 75-year-old men, your score is lower or your score is higher than other people of your peer group. So it's helpful sometimes to put in percentile risk, but the absolute calcium score is the best predictor of overall risk. This is an example of the MESA 10-year risk calculator that we use to determine is your score higher or lower. And you can see a number of questions, including age, gender, coronary calcium score, and then race, ethnicity, diabetes, yes, no, smoking, yes, no, etc. There's a bunch of questions that it goes through. If you know them, you don't have to enter them if you don't have all of these variables, but then it will tell you what your risk is based on what happened in the multi-ethnic study of atherosclerosis in that gender, in that age, and in that race, ethnicity person. So it's a nice way to calculate individual risk for the individual patients. So key points for the first section of the paper: the absolute calcium score is the best predictor of 5 to 10 year risk and should be used to estimate the number needed to treat and guide pharmacological treatment decisions. And the calcium score percentile from MESA is the best predictor of relative risk and of lifetime risk trajectory. So that's, again, the percentiles used again in younger patients most commonly, but can also be used in patients over the age of 70. So the recommendations from the paper, very simply, physicians reporting the calcium score should report both the absolute Agatston score and the age, sex, and race ethnicity-based calcium percentiles. And that's a class 1 recommendation. Part 2 goes into guideline recommendations for the use of calcium scoring. And you can see here the 2017 SCCT calcium score guidelines. These were the first large-scale guidelines that came out. And basically, they said if you have a 10-year risk less than 5%, you confirm low-risk status. You don't need to do a calcium score in most of these patients, but every now and then a calcium score may up-classify patients. In other words, we find unusual amounts of calcified plaque, and we can up-classify them based on the calcium score. The most common use is in the 10-year risk of 5 to 20%, and this can reclassify patients up or down based on the calcium score. So this is where it's recommended, risk between 5 and 20%, 10-year risk. And if the calcium score is 0 or very low, you down classify their risk. If the calcium score is high, especially above 100, you up classify their risk and treat them more aggressively. And generally, patients with a 10-year risk greater than 20%, calcium score is not recommended except in special circumstances. This was followed by the 2019 guidelines, and you can see here overall the guidelines, and then as you zoom in on that larger box, you can see that for those patients with 5 to 20% risk, ASCVD risk of 5 to 20%, if the risk decision is uncertain, consider measuring coronary calcium in selected adults. Calcium score of 0 is a lower risk, so that would be consider no statin. Calcium score greater than 100 or above the 75th percentile, initiate statin therapy. So very simple. And then 1 to 99 is kind of our gray zone where you might favor statin because they have calcific plaque, and that might depend on their age and percentile risk. So 0, no statin, and they talk about withholding statin therapy for up to 5 to 10 years. And a calcium score of 100 is just simply initiate statin therapy. So these are the 2018 ACC/AHA cholesterol guidelines. So the next section talks about in whom coronary calcium is not recommended. So generally in these guidelines, patients with less than 5% 10-year risk, these patients are considered to be generally not recommended. The SCCT guidelines say that if patients have a strong family history of premature ASCVD, you might still check a calcium score in this very low risk ASCVD category. But in general, less than 5%, no calcium scoring is recommended. And greater than 20%, generally not necessary. They're already high risk. There might be a few patients, older patients with a paucity of major risk factors where the pooled risk equations is so heavily driven by age that they're considered high risk. But if they have no risk factors or very few risk factors and their calcium score is 0, we may decide not to treat those patients with a statin therapy. And generally, calcium score is not recommended for those with established cardiovascular disease. So the recommendations in the guidelines for the second section are simple. For adults with 40 to 75 years of age, calcium scoring is useful to decide on the need and intensity of preventive therapies, class 2A recommendation. For adults 40 years of age or older, calcium scoring is reasonable with a strong family history of premature ASCVD. For patients with a risk less than 5%, to decide on the need and intensity of preventive therapies, class 2A. And for patients with clinical ASCVD, calcium scoring is not recommended. Level of recommendation, class 3, no benefit. So part 3 is race and ethnicity. And basically, what we can see here is patients, this is from the different groups, but generally whites have the highest prevalence of calcium, women have the lowest prevalence of calcium, a lower prevalence of calcium, and African Americans tend to have lower prevalence of calcium. This is data from both MESA and the Calcium Consortium. And Asian Indians from Masala generally have similar prevalence to Caucasians. The 10-year outcome data shows basically that a calcium score, this is from the multi-ethnic study of atherosclerosis, that a calcium score above 300 is very high risk, as is a score above 100, regardless of age, gender, or ethnicity. And a score of 0 is low risk. So really independent of ethnicity. This is data from the Calcium Score Consortium, also basically showing the same thing. Calcium score of 0, low risk. Calcium score above 100, high risk, regardless of age, ethnicity, or gender. So the next section is in which patients younger than age 40 should calcium score be considered. The Cardia study looked at this most carefully. Calcium score, this was from age 32 to 46, prospective NIH study, and basically just showed us that even in the young, a calcium score above 100 is high risk, regardless of cardiovascular risk status. So if you have a young patient who has a score above 20 in this study, or certainly above 100, those patients are high risk. Similar data from the Calcium Consortium, which was age 30 to 39, and again, 30 to 49, and again, high risk if their calcium score is above 100, low risk if their calcium score is above 0. And you can see here the based on heart disease, cardiovascular disease, or all-cause mortality, high risk when the calcium score exceeds 100, even in patients age 30 to 39. The Rotterdam Heart Study looked at elderly patients, basically just showed us that it's useful in patients over the age of 70, especially because it reclassifies 52% of patients in the intermediate risk category. So useful in the elderly, and the Calcium Consortium also showed very useful in the elderly population, with a big difference between calcium scores below 100 for risk and those above 300 for long-term risk. So key points are outlined here, basically just stating that race and ethnicity difference have been demonstrated, but a high score is associated with high events regardless of race and ethnicity. And calcium scoring may be used selectively to help stratify adults aged less than 40 and above age 70, depending on the individual characterizations and the guidelines. The recommendations are basically a class 2A recommendation for selected individuals under age 40 or in individuals as old as age 80 to help reclassify risk. The last section I wanted to cover is management of incidentally found nodules. Basically, we recommend following the Fleischner Society guidelines. And you can see here that if you incidentally find a pulmonary nodule on a coronary calcium scan or another CT scan, and they're low risk based on no family history of lung cancer and no smoking, no routine follow-up is necessary. If they're nodules less than 6 millimeters, and depending on the nodule size, the recommendations start to recommend repeat CT at 18 to 24 months or even higher if you find a large nodule. And of course, finding multiple nodules or in a high-risk person, the recommendations change. So these are from the 2017 Fleischner guidelines. And the Society of Cardiac CT and the Society of Thoracic Radiology came out with guidelines for incidental coronary calcium found on studies of the chest. So you do a non-gated study, but you see coronary calcium. It's a class 1 recommendation that that there should be a qualitative indication of severity. In other words, the radiologist who sees this calcium should report it as mild, moderate, or severe if they see coronary calcium on an ungated study for, let's say, lung cancer screening or chest pain or pulmonary embolism. And for those with mild calcification, a dedicated coronary calcium scan is useful to aid in clinical decision makings. If the radiologist says there's already moderate or severe calcium, then that generally correlates with a calcium score above 100, and we just would start treating them with a statin without a formal calcium score. So the final recommendations from this section: in adults found with a calcium score to have 1 or more pulmonary nodules, follow-up testing should be done in accordance with the Fleischner Society recommendations, class 1. In adults found with a chest CT to have incidental mild calcium, it's reasonable to obtain a dedicated CT scan for coronary calcium scoring to guide preventive treatment decision-making. And patients who have moderate or severe calcification on an incidental CT scan, initiation of statin therapy without a dedicated calcium scan is reasonable, class 2A recommendation. So I'll leave you with this thought. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident, such as those with coronary calcification, subclinical atherosclerosis, and inferior doctors treat the full-blown disease. And we no longer want to wait until patients have a myocardial infarction or stroke or cardiovascular death to start good preventive therapies. Thank you very much.
Well, that was a terrific presentation. Appreciate it very much. And our next speaker will be Dr. Michael Blaha. Dr. Blaha is an associate professor of cardiology and epidemiology and presently serves as director of the Clinical Research Center at the Johns Hopkins Cicerone Center for Prevention of Cardiovascular Disease. He'll be speaking on coronary artery calcium guided treatment recommendations and other considerations. Mike?
Hi, I'm Dr. Michael Blaha from Johns Hopkins Cicerone Center for the Prevention of Heart Disease. And I'll be presenting part 2 of the presentation on the new NLA scientific statement on calcium scoring. And this talk will focus on calcium-guided treatment recommendations and a few other considerations at the end. So let's dive right into part 2 of the NLA CAC statement. So here's what we'll cover in this part 2 of the presentation. Number 1, approach to the patient with a calcium score of 0. 2, treatment of those with high calcium scores, multi-vessel calcium, or left main calcification. 3, calcium scores in the setting of familial hypercholesterolemia. 4, calcium and diabetes in the metabolic syndrome. 5, calcium scoring and allocation of aspirin. and antihypertensive therapies. And then we'll have two other considerations. We'll consider calcium scoring in those already on statins, and we'll also talk about repeat calcium scoring. What is the value and when do you repeat a calcium score? Okay, so part one, approach to the patient with a calcium score of 0. Of course, the calcium score of 0 is now one of the more accepted, reassuring factors for a patient that might drive down their risk less than you would have expected before the test. For example, a patient with a few risk factors, but well controlled. If they have a calcium score of 0, their coronary and cardiovascular risk is actually lower than might have been predicted, for example, with the pooled cohort equations. So in this way, the calcium score can serve as a so-called negative risk factor. And this is in contrast to other markers. For example, a high Lp(a), for example, is a conventional risk factor that really can only drive up the risk of patients. If the Lp(a) is normal, you can't conclude that that patient is low risk. In contrast, a calcium score, given the fact that it's an imaging test with very, very high sensitivity, can identify patients who have no detectable burden of atherosclerosis and therefore are lower risk than you would have thought before you did the test. In this way, calcium score is a very unique negative risk marker. And we know that when you compare negative risk factors, if, for example, in the multi-ethnic study of atherosclerosis, that the calcium score of 0 is the strongest individual negative risk marker. That's shown here on the left. The calcium score moves down the post-test risk the most compared to the pre-test risk amongst a variety of other reassuring things, for example, like the lack of a metabolic syndrome, a healthy lifestyle, or a low CRP value. And this is consistent with the imaging hypothesis of atherosclerosis that due to its superior sensitivity, imaging tests for subclinical atherosclerosis are excellent for ruling out or downgrading risk estimates. So this is already reflected in the ACC AHA guidelines, where they give a class 2A recommendation to calcium scoring and state that in intermediate risk patients or select borderline risk patients, if the decision about statin use remains uncertain, it is reasonable to use the calcium score in the decision to withhold, postpone, or of course, initiate statin therapy. So let me go over the key points and the recommendations from this section of the NLA CAC statement. Here are the key points. Calcium score of 0 is indeed associated with a highly favorable cardiovascular and non-cardiovascular prognosis, and a calcium score of 0 appears to be the strongest negative risk marker for atherosclerotic cardiovascular disease. And in the absence of diabetes, active cigarette smoking, or a very strong family history of premature coronary disease, statin therapy in those with a calcium score of 0 is probably associated with limited expected benefit and could be considered for deferral. The absolute atherosclerotic risk reduction with statin therapy is, we presume, proportional to the calcium score thereby the conclusion that there's a probably limited net benefit when the calcium score is 0. So the recommendations for the document: in adults 40 to 75 years of age with an LDL between 70 and 189 and without diabetes, active cigarette smoking, or strong family history of premature coronary disease, it is reasonable to defer statin initiation in those with a calcium score of 0. And that's a level of recommendation 2A in the new statement. Also, in adults aged 76 to 80 years of age, in whom the decision about initiation of statin therapy is uncertain, it is reasonable to use a calcium score of 0 as a factor favoring deferral or avoidance of statin therapy. This is a recommendation statement, class 2B, level of evidence B, no randomized evidence to support this, but expert consensus based on the data. So these are our two recommendations based on a calcium score of 0 in the new NLA statement. So let's move on to the next section, treatment of those with a high calcium score, multivessel calcium, or left main coronary artery calcification. Well, we know now that a calcium score can help identify those patients who are on a continuum of risk, right? We know that primary prevention is different than secondary prevention, but really in between are those patients with advanced subclinical atherosclerosis that really aren't true primary prevention, and they aren't traditional secondary prevention, but they need to be considered a unique group on this risk continuum. We know from recent data, for example, that very high calcium scores, for example, those above 1,000, are associated with extremely diffuse coronary disease, diffuse extracoronary calcification, and actually mortality rates similar to that was observed in the Fourier trial, secondary prevention of evolocumab. So we now recognize there's a group of people with extensive calcification that have risk consistent with that of secondary prevention, and this has also been shown in a recent study from MESA. We also know that the more diffuse your calcification is, the higher risk you are. Of these two calcium scores here that are both 200, the person on the left who has focal calcification in the left main, in the LAD, is a lower risk patient than the patient on the right who has diffuse calcification in all the coronary arteries, more lesions that are less dense, higher risk. We also know that the presence of left main calcification increases the risk beyond that of just the Agassiz calcium score. If you have a calcium in the left main that's greater than 25% of the total calcification, we know you're about 40% increased risk, even after adjustment for the calcium score. So here's what the NLA calcium statement said about these topics in their key points. For a given calcium score, a diffuse distribution of calcium suggests higher risk than more localized calcification. The presence of left main coronary calcification, especially when greater than 25% of the total, suggests a higher risk patient. The calcium score greater than 100 is associated with a greater than 7.5% 10-year ASCVD risk categorically, which is the guideline-based threshold of statin benefit in primary prevention in the ACC-AHA guidelines. A calcium score greater than 300 is associated with proportionally higher risk than those with scores of 100. And those with scores even higher than 300 suggest even greater proportional benefit from LDL lowering. A score greater than 1,000 is associated with an annual risk similar to that observed in the placebo group of the Fourier trial, finding consistent with the potential value of very aggressive LDL lowering, along with other ASCVD risk strategies in these special patients. But importantly, and the guideline committee wants to make this clear, there is no evidence to support the benefit of performing stress testing or invasive coronary angiography in any asymptomatic patients with high calcium scores, regardless of the findings we mentioned. This statement strongly advises against downstream testing routinely in asymptomatic patients with high calcium scores or diffuse calcification or left main calcification. So what are the recommendations from this section? In adults with predominant left main coronary calcification, multivessel coronary involvement, or very high calcium scores, stress testing or invasive coronary arteriography in the absence of clinically relevant symptoms is not recommended. That's a level of recommendation 3 associated with harm. In adults with calcium scores greater than 100, initiation of statin therapy is always reasonable. That's a recommendation 2A. In adults with calcium scores greater than 300, and especially in those with scores greater than 1,000, it is reasonable to use high-intensity statin therapy and, if necessary, add guideline-based add-on LDL lowering therapies to achieve greater than 50% reduction in LDL cholesterol, and optimally, an LDL that's less than 70. That's a recommendation 2A. All right, moving on to the next section. What does the statement say about calcium scoring in those with familial hypercholesterolemia? As you may know, there's more data in this space recently. This is from the great data from Dr. Raul Santos' group, looking at those patients with genetically established familial hypercholesterolemia. In this population, the LDL pretreatment was 270. These were well-treated patients. Almost 100% were on statins at the end of the baseline follow-up of this study. And Dr. Santos' group showed that a calcium score can further risk stratify those patients, even with genetically proven FH, and find patients that are lower risk and at higher risk based on scores of 0, 1 to 100, or greater than 100. This is also shown in a group of patients with LDLs greater than 190 from the multi-ethnic study of atherosclerosis. Once again, those patients with calcium scores of 0 had favorable prognosis. Those patients with scores of 100 had the worst prognosis in this group. In those patients with LDLs above 190 and a calcium score of 0, the 10-year risk for cardiovascular events in MESA was only 3.7%, but reached 20% in those patients with a score above 100. And this is a meta-analysis looking at studies, predominantly those that had established genetically proven FH from the literature, showing that patients with a score of 0 compared to any score above 0 is associated with about a 55% reduced risk of cardiovascular disease. Once again, having no calcium versus having some calcium, risk stratifying those patients with FH. So what did this statement say about calcium scoring in FH? It says, in selected adults with severe primary hypercholesterolemia, in the absence of extreme LDL elevation, additional major ASCVD risk factors, or family history of premature ASCVD, calcium scoring may be reasonable to inform decision-making about the need for add-on therapy to already maximally tolerated statins. And in adults with severe primary hypercholesterolemia and calcium score above 0, heightened ASCVD risk status is confirmed, favoring more aggressive guideline-based LDL lowering in this group of patients with very high LDL cholesterol. All right, moving on to the next section. Calcium scoring in diabetes and the metabolic syndrome. So really some great data on this topic. I'll just summarize it briefly. This is data from Dr. Malik and Dr. Wong from the multi-ethnic study of atherosclerosis, showing that the calcium score can really grade the risk within those patients with diabetes and the metabolic syndrome quite well, identifying patients, once again, that are lower risk patients or patients that are higher risk based on their burden of coronary atherosclerosis. And importantly, calcium scoring stratifies risk in type 2 diabetes independent of diabetes duration or the A1C. Shown on the left are patients who have higher calcium scores and varying whether they have diabetes duration less than 10 years or greater than 10 years. And on the right, varying calcium scores and A1Cs less than or greater than 7%. If you look carefully at these plots, you'll see the calcium score risk stratifies patients regardless of their diabetes duration or their A1C. It also risk stratifies patients regardless of the use of insulin at baseline. Those patients who use insulin who had lower calcium scores, they remained lower risk. But in those patients who had high calcium scores, they were very high risk insulin-dependent diabetics. And calcium scoring has also been shown to predict risk in type 1 diabetes from the DCC EDICT trials. Shown on the left is a plot showing increased risk in those patients with higher calcium scores of type 1 diabetes. And on the right, we see the hazard ratios associated with higher calcium scores for both CVD or all MACE events in the order of about 6 to 7-fold increased risk in those patients with a score above 300 compared to a score of 0 in those patients with type 1 diabetes. So what does the NLA calcium scoring document say about these patients? Here are the recommendations. In adults 40 to 75 years of age with type 2 diabetes and an LDL of 70 to 189, a moderate or high intensity statin is indicated regardless of the calcium score, supporting the use of statins in diabetes in all patients. In adults 40 to 75 years of age with type 2 diabetes in whom the decision has been made to initiate a statin therapy, however, it is reasonable for those with a score above 100 to choose a high-intensity statin, consistent with the idea that you can further risk stratify patients with diabetes for more intensive therapies because not all diabetics are created equal. In adults 30 to 39 years of age with long-standing diabetes, as defined below, and risk factors or microangiopathy, calcium scoring may be reasonable to aid in ASCVD risk stratification and statin treatment shared decision-making in these younger patients with diabetes. That's a class 2B recommendation. In adults older than 75 years of age with type 2 diabetes, in whom the decision to employ a statin for primary prevention is uncertain, calcium scoring is reasonable to aid in statin treatment shared decision-making. That's a class recommendation 2A. So here you see the summary of the recommendations for diabetes and metabolic syndrome. Next section. What about calcium scoring and allocation of aspirin and antihypertensive therapies in the patients you're seeing in your lipid clinics? So there's lots of new data on this topic. This was data published recently in Circulation, showing that the calcium score can further delineate who benefits from aspirin in primary prevention. You've noticed in blue are all patients that were studied, and in orange, yellow, and green are increasing calcium scores. So if you look overall, the blue bar indicates the number needed to treat, and the red line indicates the number needed to harm with aspirin. So all comers, aspirin has net harm if you don't consider, for example, the calcium score for further risk stratifications on the average, aspirin will cause more harm than good in the average patient in this population. And particularly when the calcium score was 0, you can see the orange bar, the number needed to treat, far exceeds the number needed to harm. As the calcium score goes up, you see a more favorable balance between number needed to treat and number needed to harm, where only those patients with scores above 100 get a clear estimated benefit from aspirin primary prevention compared to the number needed to harm. This was recently confirmed in a study from the Dallas Heart Study published in JAMA Cardiology. Further, calcium scoring has been studied as further risk stratifying tool for hypertension therapy. And as you know, in the most recent guidelines from the ACC-AHA, in those patients with stage 1 hypertension, recommendations are for further risk stratification to figure out who should be treated up front with pharmacotherapy. This study from Circulation showed that calcium scoring, along with consideration of the pooled cohort equations, can identify those patients with stage 1 hypertension at intermediate risk who you might choose for more aggressive upfront treatment versus more relaxed lifestyle-based treatment in those patients that are have stage 1 hypertension and so-called intermediate risk. We also know from a study from the Coronary Artery Calcium Consortium, the calcium score can identify patients with risk similar to that of the SPRINT trial. Of course, the SPRINT trial showed that more aggressive blood pressure control leads to more favorable outcomes compared to more lenient control in high-risk patients. And in this study, a calcium score of approximately 220 or so identified patients with a risk equivalent to that of the placebo group of the SPRINT trial, suggesting that we could identify patients who have, in primary prevention, who have risk more similar to that of the SPRINT study, who might benefit from more aggressive blood pressure goals. So what did the NLA statement say about calcium scoring, along with as far as aspirin and antihypertensive therapy? 2 key points. 1, calcium scoring appears to reclassify risk in patients with stage 1 hypertension and may be useful for guiding decisions about earlier use of pharmacotherapy. In addition, a calcium score of about 220 appears to identify patients with annual ASCVD risk similar to those enrolled in the SPRINT trial and may be useful for guiding blood pressure targets. And I've left off this slide the fact that there's support in the NLA statement for using aspirin in primary prevention in patients who don't have an elevated bleeding risk, only when those calcium scores are above 100. That's also within the statement. Okay, next section. What about calcium scoring in those that are already taking statins? This question comes up clinically all the time. And part of the reason the question comes up is we know that statins can actually increase coronary calcification. And one of the reasons they do this is treatment with statins helps to delipidate plaque. When you delipidate plaque, you concentrate the calcium within the plaque and increase its density. And since the Agatston score is weighted by density, you can also increase the calcium score. As you can see here by CT angiography data, treatment with statins overall leads to plaque regression, but this is preferentially in non-calcified plaque, where you can still see progression of some of the calcified plaque. So the question comes up, if statins can mildly increase the calcium score, do they still have value in patients already taking statins? Well, this is recently addressed in a study from the Coronary Artery Calcium Consortium. And it turns out that the calcium score predicts risk similarly in statin-naive patients and statin-treated patients. This table shows that while patients on statin therapy are generally higher risk patients than patients who haven't been treated, because we treat patients with multiple risk factors, the calcium score can still risk stratify patients even when already on a statin therapy, with the area under the curve that's similar in statin-naive patients and statin-treated patients. And this is relevant when, of course, considering things like blood pressure goals, aspirin therapy, or add-on to statins. So what did the NLA statement say about this situation? It said that statins delipidate plaque and decrease volume of non-calcified plaque, and therefore can increase the volume of calcified plaque. But despite this, the calcium score remains a very strong predictor of risk in statin-treated patients, similar to risk discrimination observed in statin-naive patients, so still can be considered when necessary if it's going to change your treatments in things like a non-statin add-on therapy, aspirin, or antihypertensives. This differs from the ACC-AHA guideline, which really says that don't use the calcium score once you're already on a statin. This doesn't recognize the importance of situations like statin intolerance or add-ons to statin therapy, which the NLA CAC statement covers. Finally, my last section to cover today is on repeat calcium score testing, a question that comes up all the time clinically. When do you repeat the calcium score, for example, when the initial score is 0? So there's now finally high quality evidence on this topic, recently published in 2020. This is data from MESA, published in the Journal of American Cardiology, showing that the so-called warranty period, the time at which the calcium score of 0 still serves as a very powerful negative risk marker before it needs to be repeated, varies based on the risk of the patient, the gender of the patient, and the number needed to screen, the anticipated number needed to screen that you want to scan before you pick up someone with new calcification. So let's look at the top plot in the upper right of this slide. You'll see that, for example, for an intermediate risk patient, which is the most likely patient that you're scanning, if you want to scan a patient when 1 in 5 of those patients will have converted to a positive calcium score, you want to repeat the score in about 3 to 4 years. If you're a low risk patient, it's more like 5 to 7 years. And a high risk patient, it's about 3 years to identify 1 in 5 patients who's converted to a positive calcium score. This is another comprehensive study about the warranty period of the calcium score of 0 published in JACC Imaging. This study showed that conversion to very high calcium scores, like above 100, is exceedingly rare in 10 years after a calcium score of 0. Most patients remain with very low calcium scores of about 5 to 10, even after they've converted to a positive score. Patients with diabetes progress to new calcification faster than those without diabetes. And the bottom shows that the patients with a calcium score of 0 who have another calcium score of 0 5 years later remain very low risk patients with only 1.8% event rate 10 years after their repeat calcium score, so a total of 15 years of follow-up, while patients who convert to a positive calcium score do turn into slightly higher risk patients, showing the value of repeat testing. Also, there's some data out there that shows that when you already have a positive calcium score, the faster your calcium score progresses, the higher risk you are. Generally speaking, if you progress less than 15% per year of your score, you remain a relatively lower risk patient. While if your score progresses greater than 15% or greater than 30% per year on an annualized basis, you remain a higher risk patient. Once again, showing the value of calcium score progression both in those with initial score of 0 or initial positive score. So what were the key points from the NLA CAC statement on this topic? Generally speaking, and we'll get to the recommendations in a moment, NLA said that recommending timing for repeat calcium scoring depends upon the baseline risk of the patient and varies from 3 to 7 years, does not need to be repeated every year. Calcium scores increase by approximately 20 to 25% per year. So the Atkins score increases exponentially, that's important to remember. And that scores within 0 to 100 will generally have the greatest risk discrimination, which are going to help inform the recommendations I'll give in a second. Calcium score should only be measured and repeated if such measurements will change treatment decisions. And remember that calcium scores don't regress, so you can't get a calcium score to follow the efficacy of therapy, for example. Even statins can increase the calcium score. They don't decrease the calcium score. We know that to be true. In individuals who undergo repeat calcium scoring, progression of greater than 20 to 25% per year or an increase to a score above 400 in a patient with a previous positive score is associated, of course, with accelerated progression and higher risk. So what were the recommendations? In adults with a calcium score of 0, it is reasonable to repeat a calcium score at the following intervals. For low risk patients, 5 to 7 years. Borderline to intermediate risk patients between 5 and 20% 10-year risk in 3 to 5 years. And in high risk patients or patients with diabetes in 3 years. This is also what's in the recent guidelines from the Endocrine Society. In adults with a calcium score between 1 and 99, it may be reasonable to repeat a calcium score in 3 to 5 years if the results might change your treatment decisions. That's class 2B recommendation. The prior one was class 2A. In adults with calcium scores greater than 100 and an LDL greater than 70, repeat calcium scoring at 3 years may be reasonable to assess for accelerated progression to greater than 20-25% per year or an increase to a score above 3 to 400. Findings that might favor more aggressive LDL lowering in select patients, that's a class 2B recommendation, in select patients who you might want to see if they're progressing rapidly, if it'll change your treatment decisions. Those are the recommendations on repeat calcium scoring from the new NLA CAC statement. So the statement also covers some other situations that I won't cover here. talks about the future of calcium scoring, has sections on is calcium scoring cost effective? Are there clinical outcomes trials either completed or underway using calcium scoring as an entry criteria supporting the use of calcium scoring? Is calcium scoring typically covered by insurance? This is something that's increasingly true. What is the future of calcium score reporting? There's lots of discussion of new calcium scores. That's covered in the document. What is the relationship of polygenic risk scores with calcium scores? A new hot topic in the field. What new tools facilitating calcium-based risk communication are being developed? For example, the MESA CHT and CVD risk scores. So that's all the topics I'll cover in part 2 of the NLA coronary calcium statement. And of course, as we're done, both Matt Budoff from part 1 and me and Carl, of course, will be able to answer your questions and have a discussion of these new important calcium scoring statements, the first of their kind from the NLA. Thank you very much.
Well, I think if you don't get excited by having seen that, there's very little you'll get excited about with the NLA. I'm telling you, this was a terrific opportunity to work with 2 amazing experts in the field, as well as a group of terrific colleagues in the NLA who worked together to provide this statement. By the way, our calcium scoring statement is available as of now on the NLA website, www.lipid.org, and will shortly be available on as an uncorrected proof for the Journal of Clinical Lipidology. So what I'd like to do is I'd like to address a couple of questions in our remaining time. One is I'd like to address to Mike. Mike, we have a group of clinicians here who frequently encounter statin intolerance. What do you think the role of coronary calcium scoring is in the patient who has difficulties with statins?
Yeah, I love calcium scoring in this setting. I always thought it was a little unclear in the ACC AHA document when they said don't use a calcium score of someone with a history of statin treatment, because it leaves you unclear on what to do when you have statin intolerance, where a patient might not be taking a statin now, might have had some prior exposure. It's important to remember that the calcium score still predicts risk in these patients. The statin treatment doesn't alter the calcium score much. It's still extremely valuable. So I love calcium scoring and referrals for statin intolerance, where I'm not sure how aggressive to be, especially in the era of more expensive drugs that we have in our armamentarium, both what we have and on the way. I treat my patients with high calcium scores very aggressively, as we just laid out in the recommendations, and I treat my patients with scores of 0 more conservatively. I think that's immensely helpful when you have someone who's have a history of statin intolerance and whom you're unclear how aggressive to be. So I think it's in the document. We don't have as much data specifically in this group, but I think we have enough observational data to support routine use, frankly, in patients with statin intolerance whose risk isn't already extremely high.
Great. Matt, do you have any comments on that?
No, I would totally agree with Mike. I think a lot of times we find they don't have calcification, and we don't have to worry about the statin and deal with the statin intolerant patient, at least for the next 5 years.
Okay, thank you. Another question is that I'd like to address primarily to Matt, and that is, do you think at this time that there's any indication for coronary CTA as compared to CAC scoring for primary prevention?
Well, I think as the radiation doses continue to drop, CT angiography will look more and more attractive, giving us more information about plaque, about the walls, about the chambers and clots. However, now it's not currently indicated in asymptomatic people. The one place I use it, though, is in younger patients. If I can do a low dose CT angio, because I'm worried that a calcium score may not be as valid in the age under 40 group, especially those with, let's say, familial hyperlipidemia or a significant family history, where I might want to know how aggressively to treat.
Great. Do you have any comments on that, Mike?
No, I agree. I think we laid out, I think the most important point is, I think this document's one of the first documents that I'm aware of that really pushes the idea that FH can be further broken down into lower high risk FH and higher risk FH, higher risk where we want to be extremely aggressive. So yeah, CT angiography when it's available and when you can do it for a low radiation dose and the heart rate's appropriate and the kidneys are appropriate, but more routinely calcium scoring in patients with FH right now in 2020 and 2021 to guide therapy, not only of course LDL goals, but things like aspirin therapy in FH. CT imaging can be extremely helpful.
Great, thank you. Another interesting question that we're commonly dealing with is when we get diabetic patients coming in for evaluation without any established disease or perhaps in the paucity of other risk factors. I'm curious to know when you consider doing a CAC score in diabetic patients who are presenting to you for risk factor management and treatment decisions.
Yeah, I can address that first. I mean, once again, calcium scoring is extremely helpful in diabetes too. I think we laid that out in the document. We made sure in the document to say that, you know, in general, we're going to be using a statin anyway in someone with diabetes, but there's other decisions to be made. How aggressive you want to be with the statin, non-statin add-on therapy, is it appropriate? Should the diabetic patient be on an aspirin, for example? And of course, many of us are now treating with things like SGLT2 inhibitors and GLP-1 receptor agonists. And you're not going to be using that in everyone, but you're going to be using it in people who are high risk. So I think the framework we laid out in this document changes the paradigm a little bit. For when we used to have that very simple paradigm of calcium score, statin, no statin. Now it's calcium score, statin intensity, LDL goal, aspirin, intensity of other therapies. So it really speaks to the entirety of the management of the patient. There's more decisions for diabetics than just put them on a moderate intensity statin and put them on the road. So I think that's what we're talking about here in this statement. So I use it routinely in patients that are extremely high risk diabetics that are in the middle of the road.
Okay, Matt, do you have comments on that?
No, I would just totally agree with Mike. I just would remind people, if you look, there's a paper from Anand in type 2 diabetics. Patients with a score of 0 had 0 events with diabetes, type 2 diabetes, had 0 events over 3 years. Those with a score above 1,000, over 60% had an event. So not all type 2 diabetics are similar. And as Mike laid out, we have a lot of treatment options now for our patients with type 2 diabetes. So I think it is helpful selectively in type 2 and type 1 diabetes.
Type 1 too. That's a great point.
You know, one of the issues that comes up is that in the 2018 AHA-ACC multi-society guideline, coronary calcium scoring is recommended in those at borderline or intermediate risk when the decision about treatment after looking at the pooled cohort equations and risk enhancing factors remains uncertain. How comfortable do you feel with that recommendation? And specifically, do you color your thoughts about the use of calcium scoring in that group based upon the results from MESA, indicating the high percentage of patients with CAC scores of 0 in that borderline to intermediate risk group?
Yeah, I mean, I think it's a great utility. I mean, remember, from 5 to 20% risk is actually a very broad-based recommendation by the American College of Cardiology and American Heart Association. So I do think that it portends well for us to be able to identify a lot of patients who have no plaque and therefore don't need more aggressive therapy and don't need statin therapy, at least for the next 5 to 10 years.
Mm-hmm.
Yeah, and I guess we probably, maybe in the talks, didn't spend as much time clarifying where we differ from the ACC-AHA guidelines. We, of course, agree in a lot of ways, but we differ in some ways, too. I think one of the things for the viewers to gather, which I think sure you did from the talk, is that while we think that there's great value in 5 to 20%, that's concordant with the ACC-AHA guidelines. We also do recognize the realities of clinical practice, that you will see some patients that are on the lower risk side have strong family histories, for example, and other major risk enhancing factor where we do think there's value in calcium scoring, where the ACC-AHA guidelines weren't as clear. So I think that we can even shift that to even certain patients that are lower risk that have particularly a family history, more concordant with what the SCCT said in 2017, whereas I think that's where the NLA settles out here. So yeah, I think as Matt said, in non-high risk patients, basically, the calcium score in many patients has great value.
Yeah, so this is a great opportunity for us to let our membership know that really in that 5 to 19.9% risk group, in fact, the decision is almost always uncertain. It's a coin flip. 50% chance that the patient may have a calcium score of 0. So I think we're hopeful that more people will order coronary calcium scores in that group, because starting a patient with a CAC score of 0 on a statin results in a very, very high number needed to treat to prevent one event. Whereas those who have established CAC scores of 100 or greater, you're in a group where there's much, much greater likelihood of benefit upon initiation of a statin. Well, I think we've come to the end of our presentation. I encourage all of you to go to the NLA website, take a look at this document, and be aware that it'll be coming out soon in the Journal of Clinical Lipidology. It's been a privilege for me to participate in this and to share the stage with two giants in the field of CAC scoring, Mike Blaha and Matt Budoff, and we all thank you very much for your participation. Thank you.
Thank you.
Be well, everyone.